So it's my pleasure to introduce our next speaker, Dr. Adrianna Vlachos, who will speak on girls with bone marrow failure, challenges with menarche and beyond. Dr. Vlachos is the director of the Bone Marrow Failure Program at the Stephen and Alexandra Cohen Children's Medical Center of New York, an associate investigator at Feinstein Institute for Medical Research, and an associate professor at Hofstra North Shore, Long Island Jewish School of Medicine. Welcome.
Good morning, everyone. Thanks for coming so early to this session. I thank the organizers of this of the foundation for inviting me to speak today on this topic. How do we start here? I have no conflicts to declare. So the goals today, for my part, is to describe the physical phenotype and hematologic profiles of patients with inherited bone marrow failure syndromes, and I've chosen two to highlight today: Fanconi anemia, which is the most common of these rare disorders, and Diamond-Blackfan anemia, because it's a little bit different than the rest, and to describe the management of menarche, pregnancy, and hopefully to discuss some fertility and fertility issues in these patients. So bone marrow failure can be of the acquired type, as we all know, with aplastic anemia being a catch-all phrase with many, many different etiologies, from radiation, chemotherapy, and various drugs and viruses. Much of what I'll be discussing today is applicable to these patients with aplastic anemia of the idiopathic type. But today we'll talk about the inherited bone marrow failures. The ones that, the specific syndromes that go on to develop pancytopenia in general are Fanconi anemia and dyskeratosis congenita. And the single lineage cytopenias include Diamond-Blackfan anemia, Shwachman-Diamond syndrome, severe congenital neutropenia, and megakaryocytic thrombocytopenia, and TAR syndrome. I'll be using Fanconi anemia as the model for most of these, except for Diamond-Blackfan anemia, which does have things that are a little bit different than the rest. The shared clinical characteristics of these syndromes include bone marrow failure, congenital anomalies, cancer predisposition, and the very important thing for this audience is that many can present not only is in early childhood, but in late childhood, adolescent, and even in adulthood. So we have many patients that their first presentation will be aplastic anemia when they're 25 years old. And in that age group, where it's not the common type to present, not the common age to present with aplastic anemia, looking for these other syndromes is very important, not only for the diagnosis, but also for the management. So Fanconi anemia is a DNA repair syndrome. It's autosomal recessive in most patients, with 15 genes identified to date. There is one gene, Fanconi complementation group B, that is X-linked, and it's characterized by cytogenetic instability with hypersensitivity to DNA cross-linking agents. And as you can see, here in a diapoxybutane preparation, we have increased chromosomal breakage. We also, these patients, about 60 to 75% of them will have congenital anomalies of various types, the most common being the short stature and upper limb, especially of the thumbs. But some women will have female hypogonadism. And we'll talk more about that. So we'll start again with a question. So here we have a 14-and-a-half-year-old female with Fanconi anemia who has short stature and is on androgen therapy. Her hemoglobin is 10 and her platelet count is 50,000, and she has had no secondary sex characteristics and no menarche. So as the treating physician, what would be your next step? A, observe. B, start combination oral contraceptive pills. C, start low-dose estrogen only. D, start progestin only. Or E, perform a pelvic ultrasound. And we'll go ahead and answer this later. Oh, so that's where we are so far. Can I have the next slide? There we go. So Fanconi anemia, I need the slide before that. Okay, there we go. So we know that in terms of careful surveillance for the hematologic manifestations of Fanconi anemia, we know that it's associated with cytopenias that present at various times during the first 2 decades of life. And many patients will present with myelodysplastic syndrome or AML, with 90% of the patients having either a leukemia or a solid tumor by the age of 40. Treatments for these include androgen therapy, supportive care with hematopoietic growth factors and transfusion support, and the definitive treatment for the hematologic issues is stem cell transplantation. However, what our focus is on this morning is surveillance of the endocrinologic and gynecologic issues for these patients. And I'll be discussing puberty and assessment for anomalies, abnormal uterine bleeding, GU and breast cancer, HPV vaccinations, pregnancy, and menopause in patients with Fanconi anemia. And again, this is applicable to most of the inherited bone marrow failure syndromes and to aplastic anemia in general. So these patients with Fanconi anemia have congenital tract anomalies. Many of them will have hypogenitalia. They can have unicornate and bicornate uterus and have ovarian atresia. So it is very important to perform ultrasound in patients that present with delayed puberty. Puberty will often commence during the mid-teens. Often it's infrequent and it's irregular periods. And these can be due to many issues. Many can have thyroid or hypothalamic dysfunction due to their very low body weight and chronic disease issues. They can have secondary amenorrhea. Patients can be on androgen therapy, which is a very good treatment for this disease. However, it can be contraceptive and cause issues with menstruation. And in some animal models, they've actually documented, based on the Fanconi anemia gene, actual hypogonadism and impaired fertility just based on the mutation. Not shown yet in patients, but something that we have to think about for the mutation itself. So girls with FA can appear to enter puberty late. Late menarche, as defined, is no breast buds by age 13, no breast buds by age 14 in girls with low body weight, no menses between the ages of 14 and 16 or 3 years after breast bud development. And this definitely warrants evaluation of the hypothalamic pituitary axis with luteinizing hormone, follicular stimulating hormone, and estradiol levels monitored. These patients should be treated with hormonal supplementation to develop their secondary sex characteristics. Low-dose estrogen is usually the treatment of choice to optimize breast development while optimizing height. If a patient is already of adequate height, then you can go ahead and use full-dose estrogen. Progesterone is only added when breakthrough bleeding occurs or 2 years after estrogen treatment is started if the patients are reaching their optimum height. If not, then you can proceed with estrogen treatment alone before adding the progesterone. And these are standard recommendations, not just for Fanconi patients, but for patients that have delayed puberty. Some of these patients can present, obviously, with heavy or prolonged bleeding, or both, because of thrombocytopenia and the infrequency of ovulation. Thrombocytopenia, of course, can be treated with platelet transfusions and red cell transfusions for the anemia, whereas infrequent ovulation does require hormonal therapy very often. The hormonal therapies that we have available to us can include continuous combined oral contraceptives. So the patients just don't take the placebo pills that are in the contraceptive pack. These are combined, obviously, with estrogen and progesterone. And most of the time, to minimize breakthrough bleeding, they have to have about 30 micrograms of estradiol in the packet. For acute bleeding, often you need to give a bigger dose of the estradiol up front for a few days and then decrease to 1 pill daily. As we saw in the previous talk, patients can also be treated with progestin alone to decrease bleeding, using megestrol or hydroxyprogesterone. And often, because it's a hypothalamic issue, patients need to have gonadotropin-releasing hormone agonists like Lupron that are given monthly or sometimes every 3 months that will regulate these patients from having increased uterine bleeding. However, these are definitely associated with risk of bone loss. So often what we've done is use combination therapy in these girls and women, using the Lupron along with the combination oral contraceptives, and therefore minimizing the bone loss. There also can be other causes of abnormal uterine bleeding, including endometrial thickness, polyps and fibroids, and ovarian activity. So these definitely warrant further evaluation with ultrasounds, and if thickness is indicated, is seen endometrial biopsies, because surgery may be indicated for some of these girls. Fanconi anemia in particular is very associated with increased incidence of lower genital squamous cell carcinomas, specifically vaginal, cervical, vulvar, and anal cancers. In fact, this occurs at a much younger age than the general population, and in very increased fold as defined by Dr. Rosenberg and Alter in their studies. 200-fold increase for cervical cancers and 4,000-fold for the vulvar cancers. So cancer surveillance is very, very key in these children, these young adolescents and young adults. Beginning at menarche, or for sure at age 16, these patients should have an annual physical exam looking for visual inspection of the external genitalia. If they're not sexually active, then you should consider having a comprehensive pelvic exam by age 18. If they are sexually active, then they should have a comprehensive pelvic examination, including cervical cytology and a speculum exam, specifically looking for intraepithelial lesions. A colposcopy absolutely should be done if the lesions are visible or if there's abnormal cytology. And of course, a biopsy to be done for any areas that look atypical. Any history of dysplasia or lesions should warrant a twice-yearly GYN exam, and surgical treatment is definitely preferred. Chemotherapy and radiation, as many of us know, have big implications in Fanconi anemia because it is a DNA repair syndrome, and they have many side effects compared to the regular population. So most of our treatments will involve surgery. The human papillomavirus is a very important indication for these patients, and there's 2 studies, both done with the National Cancer Institute, which showed that HPV, and these were in the anogenital cancers, specifically looking at these, 6 of 7 of them were positive for human papillomavirus. So this is something that obviously can be treated, can hopefully be prevented by vaccination. And in a European study looking at the German data, 2 of 3 patients with anogenital squamous cell carcinoma were also HPV positive. This is a little bit different than the ENT cancers that also are associated with human papillomavirus. In the first study, not many patients with Fanconi anemia who had head and neck cancers, squamous cell carcinomas, had HPV positivity. However, in the second study, 15 of 17 patients with head and neck squamous cell carcinomas were positive for HPV. So this is something that is definitely recommended by our Fanconi anemia group, and is recommended to start at age 9, when normally we start usually around 11 or 12. Breast cancer has also been noted in Fanconi anemia patients with a median age of 37 years, which is much later in the general population. In the German Fanconi anemia registry, we see this as a 34-fold increase in relative risk. So therefore, we recommend annual breast exams by early 20s. Mammography is definitely recommended for patients if a mass is identified, or by age 25. To not warrant yearly mammographies, we use MRIs to avoid the radiation which can cause issues in Fanconi anemia patients, but we definitely don't limit them to not having mammographies. And many factors for these Fanconi anemia patients can influence fertility. They have a shortened reproductive life with a delayed puberty and often early menopause. They have many anovulatory menstrual cycles, leading to menstrual irregularity. They can have ovarian dysfunction, and of course can have uterine anomalies. So the pregnancy rate is of course affected. From Dr. Alter's study about 20 years ago, she looked at 110 Fanconi anemia females that were greater than 16 years of age, 17 of which were able to get pregnant. They had 26 pregnancies among them, with 19 births and 18 surviving children. only 29% of the women in general were not taking androgens and were able to conceive. If you added in the patients that were also on androgens, that overall number went down to 15%. 10 of the 17 patients that had the pregnancies also had worsening of their hematologic status during the pregnancy that required more red cell transfusions and more platelet transfusions. 5 of the 10 went on to improve once they delivered the child, but 5 continued to have worsening status, and 7 had no change in their hematologic status. So this is very important for patients that potentially are pregnant that have Fanconi anemia, and it warrants having fetal medicine working very closely with the hematologist. There were no peripartum deaths in this study. Preeclampsia, eclampsia, and spontaneous abortions were seen in these women, and therefore all of these women should be considered high risk as a high-risk pregnancy. More recently, Dr. Alter's group once again looked at these patients that have been enrolled in the inherited bone marrow failure study that she heads at the National Cancer Institute. There were 26 females that were either pubertal or postpubertal, 17 of which were pubertal or postpubertal, with a mean age of 27 years. Menarche was found in most of these to be normal, to be within the age group less than 14, and only 2 of them had primary amenorrhea at age 15 and a half, and both of those were on androgen therapy. 4 patients had attempted to get pregnant. 3 of them were found to have primary infertility issues, and 9 patients were actually found to have premature menopause with a median age of 29 years. 6 patients required menopausal hormonal therapy for hot flashes and other symptoms, and 3 patients were not on menopausal therapy, but were found to have elevated FSH and LH levels. So now I'm going to switch to diamond Blackfan anemia, another single lineage cytopenia that can have issues with endocrinologic problems as well. This is a severe macrocytic anemia with reticulocytopenia, and greater than 90% of the patients will present during the first year of life. But again, the other 10% will present during adolescence and later and into early adulthood. 40% of these patients present with an autosomal dominant disease. Less than 1% have been recently diagnosed with an X-linked disease in GATA1, and 60% of them are just de novo in the family. About 60 to 70% of the patients have mutations or deletions in ribosomal protein genes. And about half of the patients will present with congenital anomalies, craniofacial anomalies, skeletal, cardiac, renal, and urogenital in about 20% of the population. So we have another question. 24-year-old female with diamond Blackfan anemia was steroid dependent until age 10, then lost her response to steroids and became transfusion dependent for the last 14 years. She had a normal menarche at age 13 and had normal menses for 9 years and then an irregular pattern for the past 2 years. So as her treating physician, what is your next step? A, perform pregnancy test. B, evaluate ovarian function. C, start oral contraceptives to regulate menstrual cycle. D, check her ferritin. Or E, perform a pelvic ultrasound. We have our music. Different music. And our next slide. So once again, these patients in terms of their careful surveillance for hematologic issues, we know that they can have additional cytopenias and can also develop myelodysplastic syndrome and AML. And treatment for diamond Blackfan anemia usually includes red cell transfusions and corticosteroid therapy, and the definitive treatment for the bone marrow failure issues is stem cell transplantation. However, these patients can also have endocrinologic and gynecologic issues. So once again, we'll look at puberty and assessment for anomalies, iron overload, and then the cancer risks as well as pregnancy in these patients. So delayed puberty has definitely been noted in these patients, so patients should always be looked for with ultrasounds for congenital anomalies. What's different in these patients than the Fanconi anemia patients is the treatment with hormonal supplementation to develop secondary sex characteristics. Estrogen has been noted to reverse remission or the steroid-dependent steady state in these patients. So estrogen has to be used very cautiously in these patients. Oral contraceptives have been implicated in steroid failure. So we have patients that we've seen that are either on their steady state steroids or are in remission, and as soon as they go on oral contraceptive pills, come out of that state very quickly due to the estrogen. Progesterone has been used effectively both for abnormal uterine bleeding and for contraception without issues. But estrogen is unlike Fanconi and the other diseases, is a problem with these patients. And this has occurred at any age. We've had patients that have started oral contraceptives or estrogen-containing medications for good women's health that have come out of remission. Iron overload is a very, very big issue in Diamond-Blackfan anemia transfusion-dependent patients. And we know very clearly, and we hear at our hematology meetings all the time, that ferritin is not an adequate marker of iron overload anymore, and that patients can have silent hepatic, cardiac, and endocrinologic complications due to iron overload. And these patients should be looked at more carefully with liver iron concentration and cardiac T2 stars by MRI. Hypogonadism has been found in 30 to 50% of patients that have iron overload. So this must be monitored very closely. And in DBA in particular, we're seeing increased iron stores even in very, very young patients, not following the typical models of sickle cell disease and thalassemia that are transfusion dependent. So these patients can have liver iron concentrations of 8 or 10 with thyroid dysfunction, other endocrine dysfunction, even by age 5 or 10. So much, much younger than what you would expect in the transfused population. This is a study that we presented at the Pediatric Endocrine Society, and this is a complicated slide, but we looked at 12 patients that came to us, just the first 12 that came, that were mostly seen by our adult colleagues, and looking for various hormonal and any kind of endocrine manifestations. And, I lost my animation. And 7 of the first 12 that we looked at had hypogonadism. So this is something that we're seeing very often in this patient population and something that has to be looked for. And now we're doing a bigger study looking at 50 DBA patients and comparing them to 25 thalassemia patients. We've also recently published from the Diamond-Blackfan anemia registry a study of 608 patients that were enrolled at the time looking at their cancer risk. And at that point, we had a median age of 18 years, with 15 patients having solid tumors. The median age of presentation of the solid tumor was 41 years, ranging in age from 13 to 64. Of these, 3 patients had female genital cancers, which implied a 12-fold increase in relative risk. So different than the Fanconis by far, much less degree, but definitely younger patients having these cancers. And 2 patients, and now we've had 2 others that were not part of this study, that have had breast cancer at much younger ages than is normal for the population, which is usually in the 60 to 70 range, which this accounted for a 4-fold increase. However, now with these 2 new patients, this will go up slightly in the next analysis. So what about these patients when they get pregnant? So the German and French had compiled a very nice group about 20 years ago that had 60 women ranging in age from 18 to 58. 34 had never been pregnant, 14 due to medical reasons, and 4 of these involving infertility and 10 other comorbidities. 26 women had had at least 1 pregnancy, with a mean age of 24 years at the time of their first pregnancy and a mean number of 2.5 pregnancies per patient. So of these 64 pregnancies, 42 were complicated, including maternal hypertension, prematurity, low birth weight, and fetal malformations. And these resulted in 26 with fetal loss, 5 with preeclampsia, 4 with isolated preterm deliveries, and 5 in utero deaths, 2 from retroplacental hematoma, one with an intrauterine growth retardation, and 2 that had the preeclampsia that resulted in fetal death. Of these 64 pregnancies in total, there were 34 live births. 14 of these live births were DBA-affected children. Again, it's an autosomal dominant disease in most of these women. 6 of the 12 live births were for complicated pregnancies, and 8 of the 22 were from uncomplicated pregnancies. So again, just because you're doing very well either with your pregnancy or with and we'll talk about treatment in a second, you can still obviously have an affected child because it's autosomal dominant. The placenta was available for pathology in 4 cases, and 3 were found to have significant infarctions in the placenta. With regards to treatment, those 26 women, 10 were actually on treatment and 16 were off. Of the 18 women that had complicated pregnancies, 7 were on treatment, 11 were off treatment at the time of the pregnancies. Of the 8 women that had uncomplicated pregnancies, 3 were on treatment and 5 were off treatment. So even the patients that are in remission can have complicated pregnancies. So this is something, just because they're doing well with their Diamond Blackfan anemia doesn't imply that they won't have problems once they get pregnant. 11 of the 26 required institution of treatment from their remission state to treatment or an increase in the treatment during their pregnancies. Many of the women required transfusion therapies to keep their hemoglobins between 8 and 9 at least during the pregnancy. The complications that were seen were of vascular placenta origin, and this definitely required monitoring this as a high-risk pregnancy with a high level of care, regular ultrasounds, detection of congenital anomalies in the fetus, and evaluation for placental and fetal development. The pregnancy, this is a repeat slide. I apologize for that. So we're going to go back and do our questions again and see if there's a difference. 14-and-a-half-year-old female again with Fanconi, who has short stature, receives androgen therapy, has a platelet count of 50,000 with a hemoglobin of 10, and no secondary sex characteristics and no menarche. So what do we want to do? A, observe. B, start combination oral contraceptives. C, start low-dose estrogen only. D, start progesterone only. Or E, perform pelvic ultrasound. And I think many of you had it right the first time, so let's see. I think we have a comparison. It's definitely performing the pelvic ultrasound in someone that has had no puberty whatsoever and no signs of puberty. There we go. Excellent. Everybody did very well. Once we define if there's any pathology, the next treatment would be to start low-dose estrogen. And the next question, the 24-year-old female with Diamond Blackfan anemia who was steroid-dependent until she was 10 and then has been transfusion-dependent for the last 14 years of her life, had a normal menarche at age 13 with normal menses, and then over the last 2 years had an irregular menstrual pattern. So as the treating physician, what is your next step? Perform pregnancy test, evaluate ovarian function, start oral contraceptives, check the ferritin, perform pelvic ultrasound. Very interesting music that we're having. Waking everybody up. And definitely we want to evaluate ovarian function because of the possibility that she has severe iron overload since she had normal menses for all those years. And most everybody knew that, which is wonderful. Excellent. So I think I have time for questions, and I thank you very much for your attention.
Since there's a change in hormonal or response to steroids with estrogens, is there any change post-pregnancy?
I'm sorry?
Post-pregnancy, postpartum. Has there been any?
In Diamond-Blackfan anemia?
Yes.
So in the Diamond-Blackfan anemia patients, what's very interesting is that the patients that are steroid dependent often require transfusions. The patients that are in remission often require either transfusion or steroid therapy. As soon as they deliver, they tend to go back to their steady state. So many, many women that have delivered, we have one mother in the registry who has 4 children, and every time she gets pregnant, needs transfusions, and then as soon as she's done with the pregnancy, she goes right back to her remission state. And we see that over and over, that they go back to where they were. Many women, I can't say absolutely for 100% because we don't have the data on everybody, but most of the women will go back to their steady state. There is obviously something about estrogen during the pregnancy as well that kicks them right out. And we've had girls that have tried to start oral contraceptives that have lost their response and ended up on transfusions. We had one woman who tried Dun Quai, which apparently is an estrogen-containing herbal that people take for women's health. And she had been in remission. She was on transfusions until she was 5 or 7 years of age, and was in remission till she was 40, and decided to try this because she was having menopausal symptoms and really had a hemoglobin of 4 until they called us and was like, stop the Dun Quai, and within a few months, she went right back to her steady state again. So estrogen is a very big indicator in DBA in particular, not the other syndromes.
Thank you.
Thank you.